And I'm on the computer and can see everybody. I was a little worried I would just be on audio. All right, we can see the PowerPoint now. Great, everybody.
Hey, okay. Let me just check in really quick.
And hold on a quick second. Holly, if you could please mute everybody. We're getting a lot of echo and feedback.
Thank you. Can everyone hear me okay? Dionna and I are using my sort of like just my regular phone, and I'm farther away from the phone, so I just want to make sure everyone can hear me. Maybe
I can hear you great.
You can? Okay, great.
I'm muted. I have to do my introduction, so I think Holly didn't mute me.
Hey.
You sound great, and I can see a ton of people have.
Did we lose you?
Oh, no.
Jane, that was my fault.
A lot of people have joined as a team, and so they have you on speakerphone, and so that tends to give a lot of feedback. So folks, Holly has muted everybody, but we do want this interactive. So there are periods of time that Amanda and Dionna are going to ask you questions and ask for your feedback. Holly will unmute you. If you have the capacity to mute yourself, and it looks like since everybody is on via the computer, you can. On the right-hand side by your name, there's a little thing that's like a microphone, and you can just push it, and it will mute, and that will reduce the feedback if you're not talking. That when we get to the point of doing some more interactive kinds of experiences. So, people are probably still joining because we're only 2 after the half hour. But also know this is loaded with good stuff, and I don't want to wait too long. So I'm going to go ahead and start with introductions, and then I'm going to just dive into this good information and be able to hear from all of you guys about your thoughts and feedback about some different cases too. I'm excited to introduce Dionna Weixel to all of you. This is a team member that many of you probably haven't met yet, and she is just a great gem, and I'm so glad you guys are able to meet her through this text. She has her master's in science in marriage and family therapy from the University of Central Oklahoma, and finishing up her licensure in marriage and family therapy. And she is mastered a number of evidence-based treatments, working in trauma-focused CBT, parent-child interaction treatment, and of course, problematic sexual behavior, cognitive behavior therapy. Ms. Weixel works in our team member in a very important position. She's a member of the multidisciplinary team of our local Children's Advocacy Center called the CARE Center, and she serves as our liaison. And so when our families being served in the Children's Advocacy Center, particularly those with kids that have behavioral sequelae like problematic sexual behavior or severe trauma symptoms, Dionna is there to meet with the family and be a bridge to them getting mental health services. And so I'm going to share with you a lot from the experiences she has had at the Care Center with you today in being able to address this very sensitive, even taboo topic to lots of families who really struggle to even think about their child as being a sexual being. For her to be able to meet these families for the first time and be able to talk about these sensitive topics and help reduce their fears and address the myths that they've held. And so I'm excited for her to be able to share all that she's learned with you. And joining her is our Amanda Mitten, who many of you have met. She's a licensed professional counselor and also wears multiple hats. She is a nationally certified therapist in TFCBT and coordinates the training for our child trauma services at our Child Study Center at Center on Child Abuse and Neglect. and she's a trainer in our problematic sexual behavior, cognitive behavior therapy program. Man, that's a mouthful. And works especially with children that have comorbid trauma symptoms and problematic sexual behavior. Trains nationally on trauma-focused CBT, and you're also addressing the behavioral sequelae of the problematic sexual behavior. So with further ado, I'm going to pass the baton to them as they share their knowledge and experience in addressing this with families being served in children advocacy centers.
Thank you much, Jane. That was very lovely.
Thanks, Jane.
All right, well, let's get started. As Jane mentioned, there is a bunch of information that we're going to try to get to today, and I hope everyone had the opportunity to access and utilize some of that pre-work and those resources that we sent over, because the pieces that can be gleaned from that, we're really going to just quickly summarize at the early bits of this quick webinar. So, yeah, we're going to talk a little bit about that, and we, of course, would not be able to be even sitting here and doing this work in this webinar without the wonderful members of our team and the folks that came before us that have also done this work. So we would be remiss to not thank them and acknowledge all of their hard work before we got started here. So we're so grateful for everyone's work prior to ours. A couple of goals for today. I say a couple. There's like lots, but we are going to do our best to get to all of them. And so we're going to quickly talk about some research around PSB-CBT, a little bit about problematic sexual behavior, a little bit about typical sexual development in children. We hope to be able to dispel some of the myths for you all regarding problematic sexual behavior and children with problematic sexual behavior. And then Dionna is such a wonderful resource and expert in working with our CAC and working with our family advocates, so she's going to spend a great deal of time talking about how she's done a lot of interfacing with them, and then we'll do some practical examples, which I hope will really help to drive some of these points home for you all. So before we jump into some of the content, I want to do a quick kind of check-in with you all. What are some of the things that you remember from some of the pre-work? Maybe something about typical sexual development in kids. Tell me some of the things that you gathered or learned from the resources that we sent out.
And I'll have to unmute folks or people aren't going to be able to share.
So all that Dionna and I can see is our PowerPoint, so we won't know when folks are unmuted. So just whenever it seems like you're unmuted, holler at us some of this.
So if you're unmuted now,
No. Let's see, Mandy and Clay.
So folks, you're all unmuted, so you can hear some conversation.
I wonder if it's not going to be super easy to get everyone unmuted and back from folks.
It's really bad.
At the risk of talking over people, we can hear your conversations while you're on this webinar. Just make sure you mute your phone. What we choose to do, Amanda, Holly, and Dionna, is if people have a comment or question, they can select raising their hand on the WebEx platform, and Holly can let the presenters know. The hand-raising icon is to the right of your name in the participant list to where you would hear from line. So if you select the hand icon, it will alert Holly to send a question to Dionna and to Amanda. Otherwise, I'd recommend Holly go ahead and muting everyone now.
Sake of time, as people are getting muted again, I'm going to go ahead and run through some of these slides. I'm just watching our clock a little bit and want to make sure we get all of this great information. So I'm going to cross my fingers that everyone did the great pre-work. This is also very interactive.
I would like to let you know this.
Here, and I'm still getting a little bit of feedback
Holly, can you please
So
everybody?
you know how we were doing the consent certificate now?
Yes.
So during when I was doing it,
Holly, you can please mute everyone.
I'm doing this. I already filled out. I'm doing it so you kind of know what they are, and then also provide training purposes.
Yeah.
So I
Better. Thank you so much. I'm really sorry about all of that, folks. I know that working through some of the technology stuff can be challenging. I'm going to, just again, for sake of time, I'm going to adapt a little bit of what we would have typically done here. Normally the activity, and a lot of you have seen this, is really interesting and fascinating to hear from folks. But the idea is that we're looking at these words, offender and perpetrator, and we'd want to hear from folks what kind of comes to mind when you're hearing or seeing these terms. So I think it's a great idea to maybe let's try the chat function on this one. And again, Dionna and I can't see the chat box, so I don't know if Jimmy or Jane can see those, can help to moderate some of the things that folks are saying. So just throw out some thoughts. What do you think of? What is that comes to your mind when you see these two words, offender and perpetrator? Just a couple seconds to sort of throw some ideas in there.
So everybody in the bottom of it,
yes. I know it's just really quick. I was like, what's the point?
so one person picked criminal, bad person, Hillary, and her team did. Abuser was also put down. Any other teams? Again, you can use your chat bar. Just type in your thoughts. What comes to mind when you see the terms offender or perpetrator?
I think speaking to what Hillary and her team were saying, criminal, I think that's a big one that comes up, child abuser. I did just get a quick kind of blurb that showed like deviant, those kinds of things. Those are some pretty strong bits of language that we're utilizing here, right? And it kind of paints this picture of the kinds of behaviors that somebody who falls under this sort of category would be engaging in. Any other sort of thoughts that come to mind? Is there a particular like person that we see doing this, or like something that pops into our brains as far as like, this is the person that does that? Any thoughts or reflections on that?
Visual images that come to mind? Often is a person living in the basement, or a person, usually a man, driving a white van with no windows. Yeah,
absolutely. And that's a pretty clear picture, right, of who we see this person as. So a couple of points that I really wanted to drive home with this, and I have to thank, again, the rest of our team for allowing me to borrow and utilize some of these graphics. The whole point is that I put a couple of pretty strong words out there, and we had pretty clear images or visuals and descriptors for who these people were. And the person that Jane just described, often I will see this particular kind of image, right? But the reality is that there is not this sort of persona of offender or perpetrator. There's not this very clear, like, I can walk down the street and identify who these people are. The other point that I really wanted to make is that what Dee and I are going to be talking about, and who you all work really closely with, are kids. And my guess is that, I didn't see pop up in the chat box that people immediately thought, these are kids that we're talking about, or that describe these couple of words here. People said child abusers. In fact, the people that are engaging in these kinds of acts and behaviors with children. So great point to make, and you'll hear us really spending a lot of time talking about language as we go through the rest of this PowerPoint, because that's going to play such a huge role. This slide really stands out to me as something that's extremely impactful for the work that we're doing, because those words that we just used are not words that we would use to describe these faces that you're seeing on your screen right now. These are kids. kids, you all know, are not born knowing all of the rules. They're not born knowing how to follow these rules. They're really learning based on experience and modeling and feedback from their environment and the people around them. What do we know about kids? They're naturally impulsive. They often have learning difficulties. They're really active, right? They're really like sponges, and we're not talking about kids are offenders or perpetrators. That's not the language we're going to be using. And we'll talk a little bit about what language we do use instead. But the point I really wanted to make here is that remember who we're talking about, our children. They're malleable, and they can learn how to make better choices with their actions, and that they're not born knowing all of the rules. So let's talk a little bit about typical and problematic behavior in kids. Again, I'm gonna run through a lot of these things here. I think what is really important to think about and talk about here is that kids are sexual beings, and just as language develops and our cognitive abilities develop, sexual development is something that is also on a continuum, which we'll continue to talk about. And sexual development starts at a really young age. And while I'm not specifically a parent, we hear from parents all the time that it is really tough to imagine and wrap their brains around the fact that sexual development starts so young. And that's an anxiety-provoking thought for caregivers. And so I think it's challenging often and easily avoided in conversation with families. But it's really important for us to consider when we're talking about sexual development, talking about problematic sexual behavior versus typical sexual development, to think about this continuum of child development and where it's happening in that continuum. Is it considered playing doctor? And we'll talk a little bit about each of these things as well. And how does culture and society play a role in this? We would be remiss to not mention those particular factors, as every family is a little bit different. They raise their children a little bit different. Their morals and values are going to be a bit different. So it's important that we consider each of those pieces as we're making these decisions and thinking about how this plays a role in development for kiddos. Specifically about problematic sexual behavior, a couple of quick points that I wanted to mention is that, of course, it's going to be youth-initiated behaviors that are going to involve sexual body parts. So that can be genitals, it can be anus, buttocks, breasts, sometimes can involve mouth and hands as well. The distinguishing factor here is that we would consider it developmentally inappropriate, and in some sort of jurisdictions, which again, important for you all to know based on your state and your location, but it could be considered illegal. Look at a chart in a little bit that I think does a really nice job of delineating each of these different factors and sort of breaking it down a little bit. I really want to emphasize here that problematic sexual behavior is not a diagnosis. So I want to pull this back to language as well. The language that we're using to describe these children in the community, with our agencies, in front of caregivers, is going to play such an important role. And while I know that you all aren't spending necessarily, as family advocates, a ton of time introducing and talking about diagnostic information, I think it's an important point to make that this is not something that we are calling a diagnosis and labeling this child as for something that feels very permanent. It's a behavior problem that can and does need to be addressed in treatment, but it is not a standalone diagnosis of behaviors. So here you'll see, and hopefully mine and Deonna's language will continue to reflect this as well, but we're bringing the kids first here. So it's a child or youth with problematic sexual behavior. It does not define who this kiddo is in the perspective of their world and the things around them. It does not define how they are as a friend or as a kiddo. It is a behavior problem that, as I mentioned, does need some addressing, potentially in a therapeutic setting. It is specifically focused on the behaviors. Again, it's not, while we utilize the term sexual, the intentions and the motivations behind these behaviors are not related to sexual gratification. And that's a pretty clear distinction that we want to draw as it connects to adult sex offenders and folks that would sort of fall into that category. It's very different. The motivations are different here for kiddos, and we'll talk a little bit about that as well. And we'll talk about the different origins that come along with kids who are engaging in problematic sexual behavior, because there's a lot of different areas that this can really be coming from and influencing kids in a lot of different ways. So here's a continuum that I was reflecting on a few moments ago. And I think it's really important to think about sexual behavior from the standpoint of it not being very on the kind of black and white perspective. It is that continuum, and there's a lot of different spaces along. You probably can't even see my hands. I'm doing lots of gestures, but there are a lot of different ways from typical to problematic that we can help to define and sort of have a greater understanding. This particular graphic is from one of the resources that we sent out to you all, so it might look familiar to you. But I want to talk really quickly. Typical we would consider exploratory, so it's more spontaneous. It's not something that's highly planned. You start sitting down and coming up with this play of what exactly they're going to do. Mutual agreement between the children who are engaging in the sexual behavior. These kids tend to be near the same age and developmental level, so that plays a really important role in considering typical versus problematic. And it's frequent, so it's only happening every once in a while, and typically is easily redirected by caregiver intervention or redirection. On the other end of that spectrum, and again, it can fall on the spectrum, is problematic, and these are more planful. Some be considered coercive or threatening. Sometimes falls into the harmful category. We tend to see larger disparities in age ranges here, in addition to taking into account, again, developmental level. That's going to, again, play a role. We could have 2 9-year-olds engaging in behavior together. Maybe one is a child with Down syndrome. That's a very different developmental level for these children, and something that needs to be taken into consideration. And then the preoccupying piece here is that it's interfering with sort of day-to-day activities for these children. Maybe interfering from their ability to form appropriate or helpful pro-social friend groups. It's harming them from the standpoint of the classroom. Maybe there's some difficulties in those kind of things. The other thing that we sometimes see happen is that when kids are engaging in these kinds of risky behaviors, they're a little bit more isolated because that's what feels more comfortable for these caregivers. So lots of things to take into consideration here. The whole graphic that really lines out a lot of the research-based guidelines for determining if sexual behavior is problematic. I think this is something that we all have posted in our offices because it's a helpful way of considering if we would consider a sexual behavior to be problematic. So again, frequency, developmental considerations, and harm. These are all very similar to what we just spoke about. They're going to play a big role in making these determinations for kiddos. So we would be remiss to not talk about technology here. I also am watching the clock and know we could spend all day having a conversation about all of the developments in technology and how that's impacting lots of different facets of the world around us. But what I really want to point out with respect to technology is because of its rapid growth and the way that it's changing the way that children interact with one another, it's also changing the way that they access potentially explicit material. So if you think about previous generations, we really have to think about how they're accessed. These previous generations had access to their parents' magazines. Maybe it was Playboy, maybe it was Maxim, these different, a little bit more racy magazines, things that, again, were a little bit more sexually explicit. But that was very different than what we're seeing in technology. In technology, it's really easily replicatable. It's much easier disseminated. It's very, very permanent. And think about the ways that kids are interacting with each other. It's on smartphones. It's on their iPads. And what do all of these devices have? Most of them have cameras. So that plays a really big role. How are they messaging and engaging in conversation in those aspects? So I think one point that I really want to drive home here is that technology is sort of changing the way that we conceptualize these behaviors from the standpoint of the generations were engaging in similar kinds of behaviors, but technology has added another level of risk. And so it's taken something that is often, that could potentially be considered a normative behavior, but making it a little bit riskier because of the aspects of technology that are just kind of embedded in the world around us right now. Of course, we do have to take into consideration child pornography here, and the age of the kiddos accessing the things online. So, for example, in Oklahoma, it is illegal for children that are minors to watch pornography, but of course, in your states, be mindful of the regulations as well. Always thinking about long-term impacts and sort of how these things are continuing to develop. It's an ever-growing conversation that even within our teams we're talking about pornography and the impacts that it's having on children on a pretty recurrent basis. So again, we could talk a lot about that. What I want to highlight here is that, as I've mentioned, these are children with behavior problems, and there's not a clear profile for these youth with problematic sexual behavior. Not all of these kids fit into one category of demographics, of psychological difficulties or lack thereof. Not all of these kids fit into the same sort of social category. It's a very diverse population, and in fact, it's more diverse than adolescents with problematic sexual behavior and adults with illegal sexual behavior. And there's no central characteristics between kids or adolescents and those of adult sex offenders. So really need to drive that point home. Historically, I love getting on my soapbox and talking about these co-occurring diagnoses and how we often see these things in youth with problematic sexual behavior. I'm afraid we don't have a ton of time for that today, but the point I want to make is that a lot of times, and we'll talk about this when we talk about risk factors, a lot of times these children do have co-occurring diagnoses related to risk factors in their environment, which sometimes and oftentimes make them more vulnerable to engaging in problematic sexual behavior. And this is not an exhaustive list, but a list of some of those things that we would see. So again, some of the commonalities we see among these children are relationship issues. If you think about a child that's repeatedly engaging in problematic sexual behavior, that makes for difficulties in social interactions. We'll talk in a little bit about the impacts that it has on the entire family. That changes our ability of interacting with one another. It changes our willingness to engage with each other in families that are impacted by this. And so it can really increase and cause some relationship difficulties. In younger children, just sort of for some fun little quick facts here, is tends to be female and more likely to have some comorbid difficulties, some of those mentioned on the previous slide. So let's talk briefly about this impact on the family. Then we're going to talk a little bit about risk and supportive factors, and I'm definitely going to turn it over to Dionna to talk about interfacing with CACs and family advocates. I know that's why everyone is here. So I mentioned this already. It's a family problem. It's not just the youth with problematic sexual behavior. It really involves everyone in the family. If you think about your own cases and in your own families that are coming into your doors, in our situation, oftentimes children act out on other children in their own families, sometimes siblings, cousins, or other family members. That really impacts how one engages with one another in that larger family system. It can also involve lots of systems. What you all probably see, and Dionna's going to do a great job of talking to us about how to engage systems in a productive and helpful response for these families. The caregiver's response, which you'll get to see us sort of demonstrate a little bit, is going to play such a huge role in the way the child perceives themselves and the world around them with respect to the behaviors that they've demonstrated. Here's what we hear from caregivers. Feel lots of different ways: disbelief, shame, guilt, embarrassment toward different facets of their environment. It can be about themselves. It could be with respect to their kiddo, with respect to a spouse or a loved one in their families. Sometimes they're angry at their child, maybe angry at the systems because that has felt too complicated for them, which we'll talk a little bit about. Sometimes they start to, because it's highly stigmatized and stereotyped, there's so many myths really flying around about kids with sexual behavior. so they start to believe in those myths and feel really hopeless. We hear that all the time. Families come in and don't think that their kid's ever going to get better. I put that in quotes. That really be a barrier for families. And so while engagement is such an important thing, and I could talk a lot about engagement, that will be for part 2. But we're going to try to really dispel these myths and utilize modeling of our language to help families, to create a more hopeful environment for families. All right. Let's talk a little bit about origins of problematic sexual behavior. The stereotype that we hear is that because my child demonstrated problematic sexual behavior, they must have been sexually abused. And the research here shows that that's not the case, actually. That there are 4 different areas or 4 domains that sort of some predictive capabilities around origins of problematic sexual behavior. So we're going to talk a little bit about each of those very briefly. Again, could go on and on about these. I want you to really think about the kids that are coming into your CACs, into your agencies, and think about some of these things related to those families. Often what we're seeing are child vulnerabilities, behavior problems, impulse control. I've got to point out the impulse control difficulties here. If this child has a predisposition for impulse control, they learn that it feels good to touch their private parts. Guess what? They're reinforced by that. And because we have this predisposition for impulse control, it's something that as we're reinforced by it, we're going to do it more often. And maybe not in the most socially appropriate vicinities, right? And if I have difficulty in general with my behavior, it's going to be more difficult to redirect. Developmental and verbal delays. I learn differently. I interact with my environment differently. About family adversities. What we know and what we'll talk a little bit about is caregiver involvement is such a huge predictor of change for children. And if the family has a little bit more adversity around lack of supervision, lack of resources, it makes it more difficult for caregivers to be around and provide that supervision. That's going to make learning for a child much different and change some of their vulnerabilities there. Modeling of coercion. If children are seeing a lot of threat and coerciveness in their environment, again, remember how kids learn, modeling and feedback. That's how they're going to start interacting with people around them. It's what they know, and that's what they're learning. And then modeling of sexuality. And this is not just sexual abuse from the standpoint of a kind of typical sexual abuse that I think comes to a lot of our brains when we think about it, but also what have they seen related to sexual material, whether it's modeled to them, whether it's exposure to pornography or other kinds of sexual activity. So this is, as you can see, really all-encompassing, and sometimes I have to say even families come in and don't really fit into one of these categories. So while these are predictive factors, they're not things that we can 100% always group families into. So all this to say, and the take-home message here is that it's not just sexual abuse. It can be a lot of different factors for families that really lead to some of this. Now, I would be remiss to not talk about the supportive factors, too, and we'll talk a little bit about treatment outcomes, and really what we're utilizing and doing in treatment are promoting these kinds of factors. Healthy boundaries, again, modeled and supported in their home. Protection from harm and trauma to the best of this family's ability. Of course, we can't protect people from all these things all the time, but helping them with abuse prevention skills and helping them be able to develop those skills. Parental guidance and supervision. Remember, it's sort of the opposite here of some of those family adversity difficulties that we talked about. How can we help adapt and support a family in increasing their ownership over supervising their kiddo and providing them with resources to be able to be home more often, or grow their own community of social supports and those kinds of things. General healthy relationships, learning useful skills, and increasing their coping skills. I'm going to turn it over.
So now that we know how to identify these kids, what do we do next? How can we help them? So before I move forward, I want you guys to imagine if you have a kid or if you're very close to a child and you found out that they'd engaged in problematic sexual behavior. How do you feel? What would you do? What would you want to happen to that child? Would it make a difference if you knew that 10 years after successful completion of a treatment, 98% of youth had no future sexual offending behavior? We have treatment that we know that works, but unfortunately, as Amanda mentioned, these children are being thought of as dangerous, and people aren't sure really what to do with them. They're labeling them as offenders or perpetrators, and then perspective is changing, and people are treating these children differently. So we had to cover some of the common misconceptions that we are hearing, that you are likely hearing at your child advocacy centers or the agencies that you're working in. One of those common misconceptions is wondering if youth with problematic sexual behavior can live with other children. And that's a fair question. These caregivers are concerned about the safety of all involved in their home. Often they're coming in with other children in the home, and they want to know how they can keep everyone safe. And so what we know is that typically, yes, kiddos can, with careful supervision and appropriate treatment, safely and successfully live in a home with other children. So this is not automatic no. So that's the assumption and the common belief that no, just remove these kids from the home to keep everyone safe. It does depend on a number of things, and we will want to look at some of those protective factors that Amanda mentioned. So how well is this caregiver able to supervise these children? How is the child's current behavior? And if there is another child in the home who is acted out against, how are their feelings towards having this child come back into the home? But once those things are considered, again, it is possible for these kids safely and successfully to live in the home with other children. Another misconception and question that we get is, can these youth continue to attend school safely? And so even you all hearing children who have engaged in problematic sexual behavior, if you go back to maybe that child you know, and if this happened for them, what would be the first thing you would want to do for those kids? People think, well, we're going to remove them from anyone that they're around in order to make sure they're safe and other people are safe. But we know is these kids need social interaction to learn how to develop appropriate social skills. And so often kids are pulled from school. They're put in online schools. They're pulled from, maybe they're removed from their home. Maybe they're removed from other extracurricular activities that they're involved in. Not only can these kiddos attend school safely, but it can be a very helpful place for them to learn social skills and get feedback from peers on how they're acting. And so kids, yes, can successfully attend school without jeopardizing safety of other students. It is important for professionals to consider what school personnel may need to know, if anything, and how we share that information to make sure that kids are supervised well and that appropriate behavior is being engaged in. Another question we often get are, do these youth need this intensive residential treatment or need higher levels of care? So often people just don't really know what to do with these kids or where they belong. We know about residential treatment. It can last anywhere from 6 months to upwards of a year. And again, these kids are just kind of pulled from all their social activity, all their peers, all their friends. And that can be a scary thing for families and for these kiddos. We also know that there's not great evidence or support to show effectiveness of these residential treatment facilities. So behavior changes are not necessarily occurring. We're just taking the kid out of the community. So intensive residential treatment should really be reserved for kids who are demonstrating aggressive sexual behavior, intrusive sexual behavior that are non-responsive to outpatient treatment or non-responsive to caregiver intervention. Also kiddos who may have suicidal or homicidal ideation or other thoughts that may then in other ways be harmful. But when we know we have treatment that has a 98% success rate, that is outpatient, short-term, this is often the most appropriate route to go for kiddos. Youth will grow up to be adult sex offenders, and I think Amanda has already hit this very well, but we want to drive this home because this is something that is common belief not only by these caregivers but by society, and really then influencing the way that systems are responding to these children. So as Amanda mentioned, children or adolescents share any characteristics with adult sex offenders. So, and the behavior of children is all shapeable. It depends who's around them and how their caregivers are intervening. And really from that, kids can learn different ways of behaving. Unfortunately, we still receive these referrals where children are referred to as pedophiles, as rapists, as perpetrators, as offenders. And again, that's influencing the way parents, other people, agencies, systems are looking at these kids and how they're being served. So I wanted to point out this article that Barbara Bonner wrote in 1998 that found some children between ages 13 and 15 years old were required to recite phrases such as, I'm a pedophile and I'm not fit to live in human society, I can never be trusted, everything I say is a lie, and I can never be cured. So while these things may not still specifically be happening, we are trying to take these adult models and force them onto children to force maybe more safety when in fact these kids aren't dangers in the first place. They're children who have behavior issues and maybe made a mistake. So overall, evidence does not suggest that these children will grow up to engage in sexual behaviors that are inappropriate or problematic or become adult sex offenders.
I just want to really quickly, as Dionna was mentioning that, I found myself having a really visceral reaction to some of the statements that these youth had to recite to themselves and to the community. And I just want you all to take a minute to sort of reflect on maybe your initial reaction to that, because these are children, these are youth, and I just found myself immediately being like, whoa, these are kids, and they're saying these things, and felt very strongly about that. And so just taking a minute, we don't have to spend a lot of time on this, but I just would love for you all to sort of internally take a second to reflect on how some statements, I am a pedophile, I'm not fit to live in human society, I can never be trusted, everything is a lie, I can never be cured, how that feels sort of sitting on your brains, on your hearts, on your stomachs, whatever it is, with respect to youth, to kids. I'm so sorry, Dionna.
Thank you for bringing that up. So into this next slide then, that we're saying it's very rare that we see adult sex offenders who started acting out as a minor. So if we look at the population of a whole, these adult sex offenders who are we're talking to about when their inappropriate sexual behavior occurred, really that much of the whole that is saying they started acting out really in adolescence and not even younger than that. But still we hold this incorrect assumption that all of these children are growing up to be adult sex offenders and we're catching them early and we have to lock them away so they don't have access to other people. So what happens to these kids then? When we identify this, what's going on? I want to mention that Mark Chafin in 2008 wrote an article on how policies are really not based on evidence, and what we're doing for these kiddos is not rooted in what we know works. And 10 years later, not a lot changed really, and often we're seeing really separation of families or really intensive services recommended for these families or even required for these families. And then sometimes we're seeing families where nothing is even done, and that's a really big problem for how we're responding. So we found this quote that we thought was really helpful and really applicable to this question. I wish we had a policy that would be a standardized response to these kids, but to my knowledge, there is none, which is really problematic because, like I said, some kids with really light offenses get the book thrown at them. Then other kids do very serious offenses, get boys will be boys. I think typically what probation does is pull these kids out of their homes and put them in a group home, residential placement for 18 months, and that really impacts, it kind of destroys the family. It is really hopeless. That is the only thing that I know. It just varies a lot. And that is problematic that we don't have this standard response for how we're intervening for these kids or how we're helping these kids, and that's because of a lot of these misconceptions that are held. We had another quote that we thought would be helpful to share. The system that any child ends up in happens in an arbitrary and inconsistent way. And that's true. Unfortunately, these systems tend to work kind of isolated. So schools do their thing, Child Protective Services or DHS kind of does their thing, and law enforcement is separate than that. And that's only to name a few of the systems. So we're so thankful to be working with child advocacy centers and multidisciplinary teams who are really advocating for change for these kids because we know there is something that is helpful to move family forward together. So what characteristics of that thing that can move these families forward together, these effective interventions that we're talking about that have these high success rates? Amanda previously kind of alluded to, caregiver involvement is key. So all of our treatments require caregivers to be present, and that's really the critical component for success of treatment. During treatment, caregivers are taught how to engage in appropriate supervision. They're taught appropriate sex education and how to communicate that to their children and what to do if their children have questions about sexual development, about puberty, and how to set rules and boundaries around those conversations and around those behaviors in an appropriate way. These children are also learning skills about problem solving, impulse control skills. Some of those things Amanda mentioned were those that maybe predict if problematic sexual is going to be happening. we're intervening there. We're incorporating a lot of those protective factors to help these kids learn coping skills and overall how to make positive decisions, how to develop healthy relationships, and how to make sure none of this happens again, which is that abuse prevention piece. So it really goes back to those protective factors that Amanda was talking about, and this is our treatment. This is what is incorporated into what we're teaching and what we're doing. So we want to make sure that these caregivers are modeling appropriate boundaries, appropriate relationships, because we know sexual development is not all about sex. It's about relationships, it's about communication, it's about friendships, and it's going to play a big part in the lives of these children. So how are these caregivers modeling that appropriate, healthy relationships? How are they supervising these kids to make sure that they're engaging in these social interactions that are appropriate, and encouraging those skills that we just talked about that they learn in treatment? How are they opening those lines of communication to make sure that kids have an outlet to go to when there is so much technology, inappropriate, incorrect information out there? And overall, that results then in prevention of trauma exposure and prevention of a lot of those risk factors that we talked about earlier. What does this mean for you all? How does this connect to child advocacy centers? Well, you guys are the front runners. You are getting these families first. So it really starts at that first phone call, even though that is Child Protective Services or law enforcement calling to really schedule that forensic interview. That's where it starts, because as we mentioned, these are the people that are still holding maybe these incorrect assumptions, are using this language that is inappropriate and not fitting for these children. So it starts there, and it matters on the information that you gather and how you're communicating with those individuals. So I wanted to talk a little bit about some of those things. So that information initially, data is something that's going to be important moving forward because our treatments are developed to serve a preschool population, ages 3 to 6, a school-age population, ages 7 to 12, and adolescent population, 13 to 18, kind of plus. And so we want to be mindful of how old the kid is and maybe when their birthday is, when they're turning a certain age, so we can make sure that treatment is most appropriate at that point. And so we can know what type of typical sexual behavior should be occurring for this age, and is what is happening in fact inappropriate? Is it concerning? Going back to that chart Amanda used with us, where does it fall? Where does it fit? It's important to know the name and the relationship of the other person attending the appointment with the child. Is this a biological parent? Is it a foster placement? Is it an adoptive placement? Is it a safety planning place? How quickly could this child be switching homes again? And that's going to matter for treatment buy-in, and if they're even willing to do something with the child, but also for who can consent for treatment. And when we're talking to them about obtaining a referral, if this is someone who's only known this child a week, we may not be getting a lot of accurate history or information about what's been going on for this child. And also, we may not know if that's the person who will be doing treatment with them. And since caregiver involvement is critical, that has to stay consistent. It can't be someone that's going to change in a week, 2 weeks. We want to make sure that these caregivers are bought into what they're doing and that they're going to be a consistent, safe person for their kiddo. It's also important for us to know the systems that are involved with the child. So this can be a number of systems. You all work with all of them. So Child Protective Services and law enforcement are the ones we're getting most often here at our clinic. And that's important because of ongoing investigations, which can impact our services. We don't want to interfere with investigations, so to know how they're involved, that's important, but that's also helpful for us to start changing this idea of these kids as being dangerous and harmful. So the more we know who's involved and how they're involved, the more we can start to change things at more of a system level and start working with these people to help this family in a positive direction. It's important for us to know if there's any siblings or other children in the home and maybe their ages. That's important because we want to make sure there's no other services or things that need to be provided to those kids. And as family advocates, you're advocating for the needs of the family, not of this one child that is in the home. And advocates I've worked with have done a phenomenal job at making sure that the caregivers have all of their needs met, including if it's for a child that's not there that day. And then lastly, we're looking for that description of behavior, and this is where I'm saying this is where it starts. You're going to hear from law enforcement, from Child Protective Services, from whoever is calling to schedule this forensic interview, how they're looking at that behavior. What language are they using already? How are they describing this child? How are they describing the incident? And so this is where we're learning Is this already called a rapist? Are they already called a pedophile? Some of these harsh labels that are being given. Or is it seen that this engaged in this behavior, so they must have been sexually abused, so we're looking for someone else? Some of those misconceptions that we've already talked about. So that's a very important piece in moving forward with helping this family. So Child Abuse Response and Evaluation Center, or the Child Advocacy Center that serves Oklahoma County, was gracious enough to let us use their staffing sheet to show how they gather that information we just talked about. So again, getting the name of the kiddo, their age, race, and gender, which matter less to us, but that age and date of birth are important. And who is attending with this child, so biological father would be important. That is someone who may continue services with this kiddo and that we can talk to about safety planning in the home and what that needs to look like. Same for stepmom. We can engage in some of those safety planning activities and things like that with her, but we would also potentially need to let her know that it's going to be someone who has legal rights for this child that would need to attend counseling sessions or further appointments with this child. We want to consider what the allegations are. So in this instance, the example is showing sexual abuse and domestic violence, and this is a completely made-up example, but let's read it together. Joe came home from a friend's house. Mark William, who was forensically interviewed at a date previous to this interview, Joe disclosed to the father, Sean, that he tried to put his wiener in Mark's mouth. He stated that Mark also put his finger in Joe's bottom and made him smell it. Placed with his father 2 years ago, August 2016, after living with his biological mother, Carrie Smith, since birth in Texas. Joe removed from his mother's care due to ongoing domestic violence occurring in the home. Joe has had no contact with his mother since being placed with his father. So I wonder what other information you guys are already thinking about based on what we've talked about today. Information would you want to know about this before deciding or determining if this is a problematic behavior?
There is a chat box. We can try unmuting again, so we can unmute folks. But if Eddie would mute yourself while she's unmuting you, so that unless you're talking, so now everybody's unmuted. What do you think? What else would you want to know if this is the initial information that you think about serving, providing advocacy, and safety planning for this family?
I use that chat box too if the audio does not seem to be working. So Bree, I saw it pop up.
So one person put in, is this the first time this happened?
Using the lovely graphic we gave earlier about frequency, and that is absolutely something we would have to know. What other behaviors have occurred that are similar? Any other sexual behaviors that have occurred at all for this kiddo? Great question.
What are questions? What was Dad's response?
Great question as well, to know what kind of intervention do we need to do with Dad. So with this dad, how did he discipline? What kind of consequences, if any, were given past this? How is he responding to this behavior now? Those are great. Go ahead and feel free to keep typing in those questions on the monitor for the sake of time. I'm going to keep going, but all of those things. Oh, how old is Mark? That is so important because same age peer, right? We're going to look at if this is someone of similar age. I'd also be wondering whose idea was to age in this type of behavior, and then all of those other great questions that you guys have already come up with. Great work. Kind of the second
thing. Some other things I think would be important. Now, you did mention it doesn't necessarily mean they've been sexually abused, but you know, where did the child learn this behavior? If they're disclosing anything along those lines.
Yeah, right.
So anyway, quiet now.
Thank you, Jane. There's a number of ways we could go with this, but overall, you guys pointed out some things that are really important for us to know. This is kind of just a continuation of that page. We want to know, again, detective, any child protective service involvement, so we can be in contact with those people. Typically, those are the people that are coming to those forensic interviews to watch them, and that's where I have been fortunate to be able to step in and start talking to them about these kids and what these behaviors may mean and what can happen next. And that's something that family advocates are attending as well, and they can start advocating there and doing some of that great work. Knowing a history of if there's domestic violence, divorce in the home, DHS or CPS involvement and what that was for can be important for why symptoms are occurring and what other behaviors may be occurring. Another thing I want to point out is that special consideration. So this noted Joe has a speech impediment. That is so important, of course, for the forensic interviewer to know, but also so helpful for us when we're hearing this kid is medicated for this. He has ADHD. He has impulse control issues by and large, and some maybe developmental delays. Some of these things may be influencing what kind of behavior is happening. So then family comes in for that initial visit, and you guys, family advocates, do a great job of discussing how their time there will be spent. And I have just so enjoyed working with our family advocates who I've seen make these caregivers. I can really see them feel more comfortable with these family advocates, and that's because they're immediately separating themselves from other systems that are involved. So they're letting the families know, I'm not here to take your kid, I'm not DHS, I'm not law enforcement, I am here to try my best to make sure you guys can work forward together, and that's a realistic goal for most families. So they also inquire about how the child ended up there from a parent's perspective. So now we're hearing their language, maybe their misconceptions that they have, symptoms that they are seeing, and what they're considering important kind of in this scenario that's occurred. Overall, our goal is to start building rapport with these caregivers and communicating hope, and let them know that you're known in this and there's something that can help you move forward and past this.
To the last two cases?
Yeah. So we have a couple of case examples here. Again, we're running out of time, so we're going to try to get through some of this. There are a couple of made-up examples, and then we have two that are more based on some things we have seen here. We've changed a lot of the details, but kept kind of the essence for protection of the family's sake. But these are some examples that stuck out in our community. So this child experienced sexual abuse for a period of time starting when they were 4 years old. The child acted out with two younger siblings. He attempted penetration. The child has masturbated in public places on multiple occasions despite being told to stop. Caregiver reports maintaining high levels of supervision, including installing cameras and alarms in the home. So I just want to first hear, what are your thoughts or feelings when you guys are hearing this? These are the people who are coming into you and probably what you're seeing on a daily basis, maybe multiple times a day. And so what things do you have when you hear this?
Use the chat box, or you can unmute yourself. Or Holly, you can unmute folks. People are pretty good at putting themselves on mute. We're not having the background noise we had before. Emotional reactions, what are your thoughts about this case? Bad.
Yeah.
I wonder where it is bad. There's nothing.
Things. Yeah.
All of it.
The whole thing, what has happened to this kid, and now what this kid is displaying, and maybe two younger siblings were sad, and so this is important information that we want to get from this caregiver. But this is a good example, I think, of a kiddo who had a rough start, had some of that stuff happen to them, and then where intervention could have been effective, this family actually never even started services with us. But this is just an example of cases that are being seen really at the care center every day. And this is actually a younger kiddo. Again, some of this you're seeing every day.
They also put skeptical. I wonder if both of you could talk a bit about how to think about the children as children, then things are very serious. How you're able to see all children still as children, knowing this, and have there been experiences or situations that help you in being able to remind you on their core that children, and they've had life experiences that affect their decisions, and I'll be quiet. I'll let you guys answer the question.
Honestly, even just you sort of bringing that up gave me some chills around Just looking at this description of this kiddo and the things that have happened to them and the behaviors that they have demonstrated, and thinking through, oh gosh, you're right, these are really serious things, and how do we find ourselves in positions where we're going, these are kids? And I have to be really honest with you that I think a lot of that comes from exposure to it and being with these kids and seeing them interact in their own environment, seeing them playing with toys and how they're communicating, their own sort of developmental levels around just like how they're speaking with me and the words that they're using. And it's very clear that who I'm talking to and who I'm communicating with is a kid who has had kid experiences, but has also had experiences that are way above the maturity level of a kid their age. And so I think for me, and one thing that I know Dionna and I talked a whole lot about as we were preparing for this was just this word of empathy for these families. And again, for myself, it's been being around these families and being with them and helping them to get into treatment in the right way. And even changing my own language around kids with problematic sexual behavior. I've been doing this work for a little while and utilizing the language, but the way that I communicate to kids and families plays such a huge role in the way that they then engage with me and their willingness to engage and the level of hope that they then have for themselves and the world around them. I don't know, Dionna, if you have other things you want to.
I just would want to add that I have such respect for forensic interviewers and family advocates and all those that work at child advocacy centers, because as a clinician, we get to see the other side. So we get to work with these kids and see them heal and see their family move on and maybe these kids be back together again. And that, for me, is what really helps me see, like, these are just kids. I see what they're experiencing every day. So I think that is something that is potentially difficult for family advocates and those working in child advocacy centers. And I don't know how I would handle it there when this is the only side that I hear. So I do try to report back actually to our child advocacy center about not specific cases. Again, I don't want to break PHI if I don't have a release to them, but just overall, again, our success rates are cases that we've seen succeed and do really well. So they're hearing the other side of it and knowing these kids are just kids. I think by and large it helps me look at these kids have so many other behaviors throughout the day, and we're focusing on this one. Or they've engaged in all of these different things throughout their life, and this, again, is just one. And it doesn't have to be sexual behavior, but that's just how negative behavior tends to go. We really focus on it because we don't want it to happen again, and that makes sense. But then we ignore all of these positive things that this kid has engaged in, and that's one way that I think helps me focus on maybe a kid being a kid.
So what I hear is looking at the humanity of them and the opportunity to get to really know them, and the family allows you to do that.
Yeah.
And all the folks on the call have a connected treatment program. So they want to have some follow-up discussions as a team, how to get the success and progress back to family advocates and children advocacy center members, so that you can see the light at the end of the tunnel and see progress being made, and that might help that whole process. I also want to go back because someone also made a comment in terms of safety planning and wondered about your guys' thoughts. The parents saying, I'm doing high-level supervision, I have cameras. Is there any flags about cameras and alarms, or is there anything else that you'd want to up to ensure the safety planning is at the level that you think is really needed?
Absolutely. This is a great time to talk about that. We have a few slides at the end about safety planning and supervision, but watching the clock, I think this is a great time to have that discussion. So there's lots of different things that we're really going to be thinking about, and some of it I think is the logistics around, sure, cameras and alarms, and those are sort of the things that we think could potentially be put into place in these homes. But what we find ourselves doing and having a lot of conversations around, and actually we have some resources we can share with you all that are about supervision and monitoring of for caregivers of kids with problematic sexual behavior. And some of the things we're really going to be thinking about is logistics and feasibility within their own home and in their own environment. I want to really be thinking about specific eyes-on supervision of children. What I mean is not just knowing where a kid is, but being able to see them interacting in their environment and with those around them. Some of the other things, and we hear a lot that caregivers go, wait a minute, you're asking me to be able to see my kid all the time, everywhere I go, 24/7. And, you know, my initial reaction is to validate that and to say, yeah, that seems like a lot, doesn't it? And maybe they don't have the resources. Maybe they don't have the ability to be able to do that. But then how can I help to problem solve in their own environment? This is another opportunity for me to engage this family and really drawing on, again, I really, Jane, love using your word again, the humanity of the situation for these families. And we do potentially find ourselves in a position where we're asking a lot of them, but let me validate and let me engage in some strategies to help keep them engaged in this conversation. Do they not have the ability to potentially separate kids from different bedrooms? Okay, we don't have a lot of bedrooms. What are our options with living spaces? Do we have couches? Are there room separators that we could potentially help a family get a hold of? Do we stagger bedtimes? How does that look? So how can we use the spaces that they already have and the things that they already have in place, just adapt that a little bit to fit within their family? Is it a one-bathroom household? We've certainly heard that a lot. Great, let's talk about how we can set some more privacy rules around bathroom time. Are we having difficulty with showers and baths? And the easiest way is for everyone to shower or bathe together because that quickens our evening, right? Let's talk about how we can stagger those two. Does that kid need to shower every day, or can we stagger that and create some kind of schedule? There's lots of things that with respect to safety planning and supervision that we're going to be considering. What does bedtime look like? What is sleeping arrangements? What is just kind of day-to-day? How are these kids interacting with each other? Do they get a lot of outside time by themselves with no caregiver around? How can we help to adapt a family's situation as it already is without asking them to overwhelm themselves?
That is that hopefully that's a brief thing for the family advocates to do, and hopefully quickly that switches to a clinician or someone that's able to follow up with those services and continue to break barriers that may be had in the family. So I will move one more quick case example. I'm going to keep flying through this. This child experienced significant sexual, physical, and emotional abuse until her adoption at age 2.5. Such abuse resulted in death of her oldest sibling. Child was removed with 2 other siblings and placed in foster care for a few weeks until they both moved in with their adoptive placement. Caregiver reported that she thinks the child is a rapist. The caregiver reported that problematic sexual behavior has been occurring since the child has been in the home. And this adoptive mother reported participation in multiple previous treatments and having the child stay in different homes without children without success. You see at the top of that that's an 8-year-old female. Some of reported behaviors included touching others' private parts, kissing other private parts, oral genital contact, various things that were occurring for this kiddo. And again, a lot of details in this have been changed to protect services, but hearing those types of things, I want you again just to kind of think about how you're feeling when you hear this. And do you think outpatient treatment would help this family or be beneficial for them to do?
What are your initial reactions to sort of what should happen for this family? What should happen to this child or for this child? And sort of where does your brain go with some of that?
So feel free to add things in the chat box, or Holly can unmute folks and people can comment, although it seems like people have used the chat box most efficiently. So feel free to add anything in here.
Just throwing really quick, the team in Louisville, Texas is really blowing up the chat box, and we'd love to see the folks in Kansas and Chicago and other places join in the conversation and to really use this time well.
So they mentioned that foster parents need a lot of psychoeducation. You know, what struck me about this, and actually the other 2 cases, is your thought about approaching the caregiver, giving myths that they may have, and in particular, something I've heard across teams that we've trained is the caregiver not understanding why you want them part of treatment, that it's the kid who needs fixed. You must be thinking I'm doing something wrong if you want me there. How do you approach that to help them understand why they're such a key part of treatment? Other things in terms of thinking about the caregiver's need for psychoeducation and those types of things.
We talked about those protective factors. A number of those are a result of what the caregiver is doing, not what the child is doing. So we think about the kid being involved in social activities or having modeling of appropriate relationships, and those are all things that the caregiver has to make a decision will be occurring for them to occur. We also often see these misconceptions in that these caregivers do need psychoeducation. I put this to caregivers as you are the safe person and you are so clearly who wants to make a difference in your child's life, and because of that, you being there all along the way will make such a difference for them knowing that they have this stable, consistent person that isn't going anywhere is going to make all the difference.
I would say the analogy that I like to use is that when I'm talking to these caregivers about expectations and sort of the reason that we want them involved and it's so important to us, is I come in with this kind of strong handshake around why their involvement is so important. And I think our own confidence and our own belief in the ability for this to be effective and to work is really going to go a long way. Similar to how if we're modeling appropriate language with these families, that increases their likelihood to do that as well and to remain engaged and hopeful. So I often find myself also coming back to talking about how the caregiver is feeling about being involved in this process. A lot of times I hear from caregivers that they've never been involved in therapy before. Why should they have to start now? Or that they have their own misconceptions about what's going to happen in the therapeutic environment. And this is a great open door for me to be able to validate that these things have happened and really reflect on what their previous and past experiences have been like, but then to also engage them in talking about what our treatment program is going to do that's different. Or if in the CAC setting, they're passing on that referral, having language to be able to say, this is how the program will help to include you, and this is information that I know about those things. So always coming back to emotion for caregivers, because I think we often see that they're having this high level of emotion, and so it's important to come that angle and not put them down, but also be confident in the fact that I know your involvement is going to really be so vital and integral, and how neat for you and your kid to be able to heal together through this process.
And that's especially important with this case example that you have up, because they talk about being in a lot of different therapies. So spending some time hearing the story, tell me about the treatments you had before. How were you involved? What kinds of things they address? What was the approach? And you might be able to hear a theme. It's unusual for me to have families come in and say the therapist never talked to them. Right. And they have no idea what was going on in therapy because they were not involved. Well, that gives a nice door to go through in terms of helping, asking, would it be okay if I share with you about what we know, what aspects of treatment is related to the best outcome? And as what you guys have already said, how important they are as the safety structure and foundation for their children to be able to do 24/7 in the application of support for them as opposed to an hour in a week.
Absolutely. Thank you. All right, demonstrate a pretty quick role play. We're, again, being mindful of time. I wanted to point out.
So I have a caveat that I am not a family advocate. You guys are very skilled and talented, and I'm so thankful for what you do. But this is really going to be focused on this problematic sexual behavior piece, and so I'm not going to be covering everything that you all cover in your family meetings when caregivers are coming in to meet with you and talk about what's going on, but instead this is pretty geared towards getting right to some of that problematic sexual behavior stuff, and we were hoping just to make this applicable for you all. So maybe you can see this and then move forward and use some of this with things that you need. So just that caveat before we start. but I will be pretending to be a family advocate.
I will be pretending to be a caregiver.
All right, so I'll start by, my name is Dionna. I'm the family advocate that will be meeting with you today. My goal and my role for you is hopefully to be able to meet any needs that you have, to hear from you, that stuff. And I am not DS, Child Protective Services, the detective. You will have the opportunity to meet with them after your child is today. But for now, you know about being here and why you think you're here.
Well, I wasn't really told a lot, so I don't really know why we're here. I mean, I kind of know, but I just don't have a lot of information. Someone is, gosh, it makes me nervous being here, but someone was talking to my kid today about what happened, maybe, and so what happened was she was found under a blanket with her male cousin, and neither of them had any clothes on. She had previously asked another kid at school to touch her private parts. I don't know if she's ever going to stop doing this. I'm really frustrated. She's this is ridiculous, and she should not be engaging in these kinds of things. I'm at the point where I don't even want her to go to school. I feel like she had to have learned this somewhere. Someone taught her. Someone taught her about these behaviors.
Thank you so much for sharing all of that with me. And I heard a lot of things from you, and I know that it can be kind of scary to come here for caregivers and also for children. So let me start by kind of talking a little bit about what's going to happen today. But again, I hear your frustration, and my goal and hope is that we can meet some of those needs leaving so you can feel more comfortable with activities your kiddo is engaging in, and still get to just be a parent and just get to love your kiddo. I'm so thankful that your kid has someone safe who wants to support their kid and loves them so well, and that's really going to make a difference for your child.
Yeah, I mean, I really want her to be happy. That's my main goal, but I'm really nervous about these behaviors. Yeah. They're extreme and they're not appropriate, and she's the perpetrator, and I have other kids to worry about too, so she's not my only one.
Yeah, it's so clear to me that you just want really what's best for your whole family. And there's ways that I think we can go about doing that. Your kid has made a mistake, and I wonder if you know anyone else in this world that has made mistakes. I wonder if you know anyone that hasn't made a mistake.
Yeah, probably not.
It happens. It happens. Yeah. Our kiddos engage in these inappropriate behaviors sometimes. Sometimes they're sexual in nature. Sometimes they're lying or stealing, or they look different ways. But I know this is something you have to manage. So I want to talk to you about some options for you, how we can go about moving forward past this. And there are some services, if it's okay, I'd like to move forward in talking about. Is that okay?
Sure, yeah. I mean, I guess I'm willing to try anything. I don't know what to do, so.
Yeah, and we hear that a lot. And again, you being here today is what you need to be doing. Your kid has someone safe for them that is consistent, and again, that's what's going to make a difference. So some of the services that I want to talk to you about, we see a lot of kiddos here who engage in this type of behavior, and sometimes that surprises caregivers to hear that this happens often, but we know kids are sexually developing. A lot of times kids don't have great impulse control, so something feels good or they're curious about something and they're engaging in those types of behaviors. But there are ways to set great boundaries to make sure that these things don't happen again in the future. And so one of the treatments that I'm mentioning, problematic sexual behavior, cognitive behavioral therapy, really a mouthful.
Oh, it is a mouthful. I'm not going to remember that.
No, and you don't have to. But to just say that there is treatment for kids who have engaged in kind of boundary breaking. And this treatment focuses on teaching kids good skills around impulse control, good problem-solving skills, how to identify feelings and regulate feelings with good coping skills, overall skills you would probably want your kids to know anyway, and apply to a number of behaviors, not just sexual behaviors. It's also important for me to go ahead and say that what we know from this treatment is that sexual activity is just a behavior. It's not anything more than that. Your kiddo engaging in this doesn't mean we have no research to show that this is just going to continue and be a lifelong problem. Actually, we have the opposite. So what our treatment, the information we have about this treatment is that 98% of the kiddos who successfully completed this 10 years later had not engaged in another sexually significant behavior that resulted in treatment again. So very highly successful and pretty short term.
Okay.
Also, I think this might be a good fit for your family because it involves high caregiver involvement. That's the critical key piece of change, is that a caregiver is involved in treatment every step of the way. And you being such an involved caregiver, I think this would be a great fit for you all and what can happen.
Okay. It seems like it could be really helpful.
Yeah. I also heard you say that you're worried about maybe some other kiddos in the home, this kiddo going to school. And so I want to talk to you a little bit about what you can do about some of those things. So I'm happy to make a referral since we're saying that that could be something that might be helpful for you, but I know it might be helpful to take something home today to start applying. In your home, something you can go immediately do. So let's talk about what you're going to do in the home to make sure everyone is safe.
Okay.
And that is that what we know is that your kid is still your kid. And probably there's some really great things about her
she's so
that you just love.
Yeah.
Yeah, and it sounds like you do have a really great kid, and so she wants to go home to her siblings and her mom, and they likely all want the same thing, and I know that's what you want for your family. And so let's talk about, again, what you can do when you get home. Some of these quick, easy things, not say easy, sometimes they're not, but you can just eyes-on supervision as best you can and as often as you can. So if it's not you, then someone else. We want to have eyes-on supervision of your kiddo at all times, and really even ears-on, so we're hearing what's going on with them. And that's going to help us guide them and start shaping behavior, setting boundaries, and making sure if they're breaking boundaries, then that there are consequences. That's the other piece that this treatment is going to focus on. It's going to focus on sex education. That's appropriate, developmentally appropriate for your kiddo. It's going to focus on setting good boundaries and helping them overall make good decisions for some of these things, as well as teaching you how to implement those skills. But start home with just keeping supervision, keeping eyes on supervision of the kids. May mean that they are not sleeping in the same bedroom as another kid. Is that something that's doable for you?
We'll have to, we'll really have to work on it, but I suppose it could be.
Some options that we often like to talk to our caregivers about. Sometimes kiddos can sleep on the couch because this is not forever. It's a very short-term kind of solution until we can get you into treatment and get you working on some of these things. Sometimes it's okay for kiddos to sleep on a couch. Sometimes our caregivers want them to still have a room and a space, or our caregivers sleep on the couch and their room for a bit. Maybe another child moves into their room and things are rearranged kind of that way. Very briefly. We want to make sure this kid's not left in charge of other children, so they're not babysitting, they're not changing diapers. We want to set very strict rules around bathroom time and bath time. We want to limit any forced play wrestling that may be happening in the home, because that's easy time to kind of break boundaries with other kiddos. And so these are just some supervision things that you can really start now, really start doing with your kiddo to make sure she's safe. And then we can get treatment started for you and your family. But it sounds like you have a great kid, and I'm excited that she has you to move forward with her.
Thank you.
Yeah.
Time. This is really, really quick because, again, we're watching the clock. But I hope it gave you some info about some of the language that Dionna was using to try to engage this caregiver, providing info about supervision and monitoring, but also talking through treatment and some of the expectations for that. So we might quickly, again, watching the clock, talk some about these treatment pieces, and then we'll maybe stop for some questions and wrap us up.
Sounds great. Yep. So you guys we just talked about those supervision recommendations that we want caregivers to hear. So there are also some rules that I'm briefly going to go over with you that you can hand out to families that become rules they incorporate into their home. That's something else, if you have more time, you want to talk to caregivers about what kind of rules do they have around modesty. And then you want to gauge how bought in are they to maybe going to treatment and doing something like that. And obviously you'll have more time to spend kind of building that rapport and doing some of that stuff with them. And this is where those multidisciplinary teams really come in handy. We want to work with them to make sure service is appropriate. So the sexual behavior rules you can see here, I believe you guys got these in your pre-work. So,
and your sites that have the clinical programs that are doing PSB, CBT also should have posters and all sorts of handouts and access to our NCSBY resources as well, which is where all this can also be found.
So these are just simple basic rules that cover most sexual behavior. So we want them for all of our kiddos, just like any other rules they have to follow. So we have different rules for our 6 and under group, just for a bit adapted to be a little bit more simple.
And I wonder, we really briefly went over some of the prevention and response stuff. I also think that since we're doing a part 2 in January, I think, end of January, I wonder if we could collapse, because a lot of this and getting caregivers to engage in some of this does come back to some of the engagement work that we're going to be talking about. So while I think it is great stuff, and Dionna also mentioned some of these things in our quick little role play, but I wonder if maybe we'll revisit some of this and leave some time for some questions here, if that feels okay to everyone, or Jane, if you have other thoughts.
Kind of rest boil down to decision. And this is stuff that we spent time talking about.
And get that on the email. So I think it would be great to see if there's any questions for these last 5 minutes.
Let's do it. And while you're formulating questions, here are some take-home points that we sort of just pulled together for this. To the chat box, or if we can get the unmuting to function well, we can try that too. Feel free to throw some questions at us that you feel like would be relevant for the groups as well.
Do you have a question?
I guess the only thing is if they're recording it, would they tell us where they send it to, or if it's just sent to my email? Or...
Put your down, so you should get it.
You guys are not muted now, so we can hear you. If you have a question, share. Otherwise, we can just mute, and people can use the chat box. It's a few more minutes. I think you hit the main points that were asked by the senior leaders. One really thing that I wondered about, let's say you're working with a family and you have some concerns about the safety planning, are not quite sure how to address it. Your thoughts about how the family advocate might be able to support the situation in the moment?
No, I think that it's important to reiterate the role of the caregiver in developing these different behaviors and what needs to happen next. And so I think the best thing to do is give them realistic things that they can do, so it feels impossible maybe to give them a different room, or maybe it feels really like I can't go get cameras and door alarms, and I'm not going to do that. My kid just shouldn't have done this. And so really you're just working to kind of, again, kind of get that soft side, like I did with Amanda. There's some things that you really love about, oh yeah, well she is, oh great, your kid sounds lovely. So we're getting back to, this is just a kid, and this is what you have to do to make sure they're safe right now. So it may come down to just giving them those things that they can do at home right when they walk out of the door. So you can right now go home and provide a higher level of supervision. You can maybe monitor what they're watching on television. You can make sure they're in front of you when they're on their technology. You can do some of these things, and that's realistic and doable, and working through barriers as they come as best you can, but as simple as you can, giving them some things to take home.
You did such a nice job validating their role of parent, validating that supervision is hard, and supporting that it can be realistic if they can think about it short term and not forever. Right. And that short term, not forever, helps them have a sense of hope that treatment can work. The other thing, again, every family advocate that is on this call is connected to a treatment team. So maybe together as a team to figure out what's the best way to do a warm handoff when you have a high level of concern. There may be a standard approach of the warm handoff and a standard approach in getting them in for intake and treatment, but is there a way to manage more priority cases that you're like, oh, we need something right away? It may be a debriefing session and until you can do an intake, but something that can support the family in the moment. Because I think that's something that I hear repeatedly you've done with the care center, is that here's a mom, a dad, bawling, falling apart, feeling hopeless, and they do need some time with the therapist in terms of being able to debunk those myths and have a sense of hope to bridge them then to when they can get into treatment.
Absolutely.
Work, guys, this is great, and again, it's recorded. So if you have team members who couldn't join that needs the information, just let us know and we can get you linked to it. It's hard with the webinar not to see your audience read facial expressions and get that immediate feedback. It was excellent job, and
Thanks.
appreciate everybody that's been on and attending and listening, and hope everyone has a fantastic rest of your day.
We're so grateful that everyone was able to
Yeah.
attend, and thank you so much for allowing us to do this, and we look forward to part 2 after the new year.
Yeah, thank you for all you do.
Thanks, everybody.
Thank you.